Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Alec. How you doing this morning?
Oh man, always a privilege and a pleasure to spend some time with you, man. Thanks for the invite.
Oh, yeah, my pleasure is mine. Today we got another research paper. I would say research in quotation mark. And this had more to do with just a question that I had. And it's about forced vital capacity. And in my head, I'm thinking in the context of chest trauma, whether that be blunt or penetrating. What did you think about this paper?
Well, Mama always said never be rude and answer a question with a question, but I'm going to do just that, which is, what is it about this paper that was intriguing to you, besides the fantastic name of the journal?
Right. Well, one, if it's got a French name on the top, it instantly is much more smart. But how did I come across it is just me asking Google lots of questions, and then this kind of floated to the top. And it showed me that it's kind of possible. It was not in the context of the environment I was in. It was not in necessarily even the patients that I was talking about, nor were there the pathologies that they're looking for, even what I was necessarily looking for. But I essentially Googled until I came to yes.
Which is so great because, I'm going to take a quick tangent here, for business development, for government services. And I think most importantly, what I've come to appreciate over many years of maturing as a soft enabler, the answer is always, how do you get to yes? So yeah, I like that. And for those who might not have access to the video, what Dennis is talking about is an article titled Forced Vital Capacity Assessment for Risk Stratification of Blunt Chest Trauma Patients in Emergency Settings. It's a preliminary study from a number of what look like pretty prestigious authors from a single level 1 trauma center in Bordeaux, France. And the journal's name, which I'm going to butcher terribly in my terrible French, is Société Française de Anesthesia et de Réanimation. And so this is a preliminary study. And I would say I share your interest in terms of managing chest wall injuries. It's an incredibly important topic, and it's so important that the JTS even has a clinical practice guideline. You can see there the wartime thoracic injury, which again, foot stomp, all those JTS CPGs are available through Deployed Medicine. And as one of our NATO partners taught me a couple of years ago, if you're overseas, that is fenced through our firewall. So you have to use a VPN to come into a US IP address. But then you can get all those JTS CPGs, which is incredibly helpful. And why do we, as healthcare providers, as folks contributing to military medicine, or even if you're a component of the JTS, why do we care about chest wall injuries, whether blunt or penetrating? Because as we have all probably learned on day one, for whatever level of medical training you're at, blood goes round and round and air goes in and out. And both of those things happen in the chest. And so if you're not able to move blood round and round, or oxygen in and out, things get bad. And so this picture came from the internet. It's definitely not considered PII. I think it was, I want to say, Southeast Asia somewhere, but I mean, anytime you get 1-inch rebar going through somebody's chest in multiple dimensions, that's worth keeping an eye on. Absolutely terrifying. If you saw somebody like that, Dennis, is that a good day, bad day? What are you going to do with that?
Well, it's not my bad day, that's for sure. But what am I going to do with that? I guess how fast do I need to go? So if I need to go right now, we're going to secure that in place. I'm going to cut him loose from whatever he's on, and we're going to load him and go, while simultaneously running through several CPGs in my head of what I'm supposed to be doing and trying to mirror that as close as I possibly can.
Yeah, 100%. The fascinating thing is this guy's got a couple pieces of 1-inch rebar stuck in and out of his chest wall, and he's laying in a hospital bed with a non-rebreather mask on. So he made it all the way off POI, wherever that may be, through a transport, got registered in the ER, and is still doing fine on a non-rebreather. It's just terrifying to me because that's accurate the picture. But chest wall injuries, they're real. In GWAT, the U.S. military ended up doing a pretty good job minimizing chest wall injuries, because we were really dealing in a coin environment where it was small arms injuries or IED blasts, and so the chest ended up being a bit more protected. We were just did a thing recently with some partners who were dealing more with a LISCO type environment. And you can see there on the slide their most recent data, which thank you so much, guys, for sharing. It's incredibly important to share this data. 7.2% of their casualties in this particular environment that they were in for this particular presentation they had, 7.2% were chest injuries. And that, of course, varies depending on what kind of operational environment they're supporting. And then, as we all know, the rapid evolution of the use of technology in UAS seems to be changing the injury patterns pretty quickly. But round numbers, 10% of your combat injured casualties are getting chest wall injuries. That's kind of a big deal, especially since, again, oxygen, blood, super important stuff in the chest wall. And so I think the why do I give a shit, which was the strategic intent of this line, which I thought was a snappy acronym. WIDIGAS, I think that might be the new acronym. Oh, because hopefully you and I aren't doing PFC anymore. We're too old for that. But if you are with a chest wall injury, that's not necessarily a good day, which is why a number of folks have looked at chest wall injury treatment and prognostication algorithms. And there are a number of large trauma organizations in the US that have really great CPGs. Obviously, I am biased towards the DoD's Joint Trauma System CPG, because not only are they a group of fantastic medics, nurses, ER docs, and surgeons that put those together, but it's also viewed towards the lens of combat and austere practice patterns. There's also a couple of really good civilian practice organizations. The two biggest ones for trauma are the Eastern Association of Surgery for Trauma, their acronym is EAST, and then the Western Trauma Association, the WTA. And you can see here that the WTA published a really great clinical decision in trauma management of rib fractures, because that's what we're talking about with these blunt chest wall injuries. And that was published in the Journal of Trauma and Acute Care back in 2016. And for upper list of many authors there on the far right, Marty Schreiber is actually Colonel Schreiber in reserves, who has done a phenomenal amount to really translate civilian practice to military trauma surgery, as well as taking a lot of his hard-earned lessons from deployed military medicine to the civilian practice. But I think, Dennis, what you may have come up with is, if we are trying to make recommendations to medics in the field about how to manage blunt chest wall injury, how easy can we make their job? And I don't know if you had a chance to look at this yet. Did you look at the WTA clinical decision rubric? check this out. I'm amazing.
Oh, it's super clear. I'll just laminate that and put it in my chest kit there.
So I know not everybody has access to the video. So what are you seeing there for that treatment algorithm for broken rib fractures?
I mean, this looks like a puzzle you'd get in the newspaper. That'll suck up a good hour of your time. But yeah, like under stress, there's no way anybody is reading this. Under stress, for certain. Drinking coffee, yes, you can flow through it. Okay.
And
yeah.
And the other thing is, what are you noticing at the very, very top?
Oh, let's see. We have 2 or more rib fractures.
Right. And I guess the question for my mind then is, if that is the very first question you've got to ask to use this treatment algorithm, how are you diagnosing that in the far forward environment? I mean, ultrasound's great for rib fractures, but the ribs have to be in the right place.
If he's got a flail chest, then yes, he applies here. That would be an obvious one. I could be a jerk and mush on his chest. Hypermobility, like he would not like me anymore after that, but I guess we could do that. But just kind of going through the best I can here. Pain control. Okay, let's see, don't have to deal with anybody 65 or older generally, unless you're talking about civilian population. So essentially it just goes down to pain management after that. They're looking at the older folk. Now they're talking about they're going directly to the ICU, probably because one, the pain, and now we're decreasing tidal volumes, minute ventilations, which sets them up for infections and et cetera, if I had to guess.
Yeah, exactly right, which is going to be at the heart of the study here that you picked up. But, I guess my frustration with trying to apply this treatment algorithm to the forward environment is the very first question you have to ask is a diagnostic imaging question, which, really the standard practice that we're doing at the trauma centers for diagnosing rib fractures is CT scans, because they're just so much better. So not even really X-ray, which I know many folks have. Reading an X-ray in the forward environment can be a bit more challenging. You certainly can diagnose rib fractures with an ultrasound, but it really matters not only how good you are at the ultrasound, but where those broken ribs are, because a not insignificant amount of the ones that we end up seeing on a regular basis in our civilian trauma center are underneath the scapula. Can see that with an ultrasound, or if any of those broken ribs have caused a pneumothorax, which has violated the pleura, and then you have a bunch of sub-Q air. I think we all know what any air does to your ultrasound image. And so this isn't a great algorithm for the forward environment.
I mean, can we go back one, please? Back to that.
You can do whatever you want.
Algorithm.
You're the boss. Yeah.
And now that I'm seeing it and I'm contemplating it, do they have more than 2 rib fractures? How old are they? If they're above 65, they go to the ICU. If they're below 65, just stick them wherever you need to stick them. And then pain control. And even on the complicated side, all of those things, like I'm not seeing any actual, there's one. Sorry, rib fixation, early rib fixation, way down the list. But everything else is just pain control. Why can I not just say, I think he's got a rib fracture, do pain control, and now I've accomplished 95% of pain analgesia, regardless of how you get it done. I've already accomplished 95% of that algorithm. I can't wire ribs. So I've, at least in my capability, I've done pretty much 100%. And then you add in nursing care on top of that, turn, cough, deep breathing exercises, etc. And I've achieved the spirit of this algorithm. Like if I'm wrong about him having a rib fracture and let's say it's like a real bad bruise, does it even matter? At least when you're talking about the rib fracture part, excluding like the pneumothoraces and all that, all the complications from that. Does it even matter?
Well, I mean, that's a existential philosophical question, which I really like to get into, usually over some adult beverages. Yeah. But you ask the reasonable question, which is, why are we doing all of this? And it took me a long time to really appreciate the differences of why. If you're in a civilian hospital, in which case we're really harshly created by all of the government entities for missed injuries, which cause a worsened patient outcome, which is a good metric to look at. Versus in the military, if we're talking about operational support in the combat environment, I think our main goal as medical providers is to enhance the fighting force. So that's really how quickly can we get trigger pullers back to the front line. But regardless, both of those are disposition planning. What level of care can we send this patient to? And what amount of resources are we going to need to allocate to this patient to send them to the right disposition? And so that disposition in the hospital can obviously be either discharge to home, perhaps ER observation, go to just a regular hospital floor, like what we call med-surg, or perhaps the ICU if they need intensive nursing care, or UBRA, which is, again, something that people tend to get fixated on, double entendre. But rib fixation isn't a means to an end. It is simply a resource that we can allocate to a patient to come up with a disposition. And there's been a bunch of really great research that have shown in the right patients who have rib fractures, if we don't do anything, they're going to end up having such poor respiratory effort, if you want to be a schmuck, that they're going to end up not breathing well. And they're going to end up needing a ventilator, to your point earlier. And that causes all the downstream sequelae of pneumonia and all that. So there's a lot of really great grading algorithms out there about who we think is going to have a bad outcome from blunt chest wall injury. And if we can identify those patients early, we can resource them appropriately for an adequate disposition, which again in landline varies. My goal for those folks depends on whether I'm in a civilian hospital or in the far forward environment. And because I like to share good resources, MD Calc, which is free and I have no affiliation with, has a bunch of great grades and scoring systems out there. And I've got the app with a bunch of them saved for offline use. The Denver criteria is kind of the national standard for a lot of these rib scoring systems. And that was originally designed for trying to identify which of your broken rib patients in the ER you need to send to the ICU for very, very frequent respiratory therapy, nursing care, and close observation to try and prevent that patient from getting on a ventilator. This new rib score, you can see, has a couple of diagnostic criteria. Again, for those who might be driving or not watching the video, Dennis, what do you see are the scoring criteria for this rib score?
Well, it says greater than, or first one is greater than equal to 6 fractures. So just the fracture, not necessarily different ribs. Are they bilateral? Then they add flail, so now you can talk about, 2 or more places on one rib. Let's see, displacements of 3 or more fractures, first rib fractures. So that's definitely going to be bad because you're under the clavicle there as well. And then fracture, one fracture or more in all 3 anatomic areas. So anterior, lateral, and posterior. So it looks like when it comes to fractures, they've covered all the different types.
Mm-hmm. And then in the very bottom there, what's the guidance from this scoring system about what scores you need to worry about and what it does?
So once you add all those up, so each one would be worth 1 point if you answered yes to them. And if you have 4 more, then the greater the risk of pneumonias, respiratory failure, and needing to take their airway.
Yeah, so again, this is just a different way to think about how to risk stratify your patients to determine what resourcing they need. And so this is a little bit more of a bigger blow up, saying essentially the same thing. And then, critical actions for higher risk development of delayed hemothorax disease processes is respiratory deterioration, more than 6 rib fractures, post-operative patients, those on anticoagulation. If you're taking care of somebody in the forward environment that's on anticoagulated, that's a really bad day because we have called up all retirees. And I sure hope that none of us have to deal with that. Or, of course, if somebody has a chest tube that's been inserted and then removed. So get back to this study that you identified. It uses forced vital capacity as a measurement to risk stratify your patients to determine who's going to have a bad outcome, to try and identify the appropriate disposition for those patients. And to put you on the spot a little bit, are you familiar with the forced vital capacity?
I am familiar with what it is. To be honest, normals, I have never had to know that.
Yeah. And so it's this article that they actually used a spirometry to get the forced vital capacity. And there's an example of a spirometer there on the screen. Do you guys use those much? Have you seen an actual spirometer? I'm guessing probably for like dive or jump medicine or something in the clinic.
Maybe. I've used the little bedside expirometers there that like you would do for nursing care. And I thought so hard about this entire topic. I went and bought a forced expirometer. This one is huge and it's probably like really, really accurate. But the one I got was like this big. It's, I don't know, about half the size of your cell phone. And it spits out a number. But I don't know, it was meant for exercise, just to train your lungs, I guess. But I've just been kind of playing around with it, to be honest.
Yeah, fair. And so that's one of the questions that I've got about this article is they talk about the forced vital capacity, and I had to do a quick internet search because it's been almost 20 years since I did family medicine, which is when I did a lot of these spirometries. And so forced vital capacity is basically the entire volume of your lungs. So you take a huge breath in and then you blow out as hard as you can. And that entire volume of air that you breathe out is your forced vital capacity. And it's my understanding that you actually need one of these fancy computer things to measure that. So is that helpful for us in the far forward environment? Maybe, maybe not. I know all of you guys out there have to do MPT, and you've probably seen the little disposable incentive spirometers in the hospital. We use those all the time on basically all of our surgery patients because they're just laying in bed with a bunch of opiates and they need to remember to take deep breaths. And so those disposable incentive spirometers have certainly been well studied. Here's a great article that I was able to find from 2019 in the American Surgeon, and it said bedside incentive spirometry predicts risk of pulmonary complications in patients. And we certainly use that little disposable thing that looks like that all the time in the hospital. Is that what you ended up buying?
Yeah. No. Mine is a digital version of that.
Oh.
But I've used those many times.
Yeah. And so what's interesting about these is, if I remember correctly, man, shooting from the hip here, I believe it's 15 cc's per kilogram of ideal body weight is your goal incentive spirometer for that. And so we can pretty easily measure that bedside with folks. And this device here is actually pretty big compared to a lot of the ones that we have in the hospital. But those are pretty easy to carry around. I wouldn't have it in my ruck.
No. But like the guys at work, you tell them it's like lifting weights for your lungs, and they're like, bro, and they go for it.
You're really good at that. I think you might have done that once or twice. So getting back to this particular study, in terms of looking at the PICO for the study, what was your understanding of the population that was studied?
Let me see. I can tell you exactly here in a second, but I mean, the population, it's one center. Let's see, they had 62 total. So we're not talking great big numbers, of people. Let's see, intervention. Yeah, they did spirometry on them. But I want to say it was at discharge. Just trying to remember off the top of my head, not looking directly at my notes all the time, but, which is kind of, it's like an afterthought. Hey, on your way out here, can you blow on this? And the idea was, if their volumes were low, did that correlate with any problems that they had during their stay?
Yeah, 100%. The thing that we always have to bear in mind when we look at all of these studies, though, there's a number of them. So in terms of the population, this was a prospective observational study. So observational, of course, means that there was no experimentation arm. So they all just kind of got the same care, and then you looked and saw what happened down the road. But you mentioned that there were 62 patients that were included during this time period, which I think was 16 months. How many were attempted to be enrolled? Do you remember how many were disqualified from the study?
No, I did not.
It was almost 50%. Yeah, that's kind of a problem. That right there should be a red flag.
Yeah.
So I think there were exactly 120 that were attempted to be enrolled. They were disqualified for a number of criteria. Encourage you to read the article for being able to enroll 62 total. There is no firm cutoff for disenrollment in terms of a red flag, but the fewer the better. And it really just kind of makes you ask the question of how well was this study structured if their clinical question didn't apply to half the patients that they screened. That's a question. That's a problem.
Yeah, I guess just looking at their exclusion criteria, if they were mechanically ventilated or required intubation, to save their life.
Mhm.
Was one of the big ones anyway. Emergency surgery or decision for to limit life support. Like somebody decided to mechanically do something with their lungs, right?
Mhm.
Does that kind of not also fall into the spirit of what they were talking about, or at least in the spirit of what we're talking about? Is they're doing it after the fact, so I guess I can kind of understand why they excluded them.
Mhm.
But if it was, I don't know, I guess let's say this was a prospective observational, but we moved that measuring point to the beginning, maybe beginning, middle, end, something like that. Would you not include those same people that they excluded?
Yeah, it's a fair question, and I actually think you bring up a good point, which is there's a perfectly understandable and justifiable reason why those patients were excluded, because essentially if you're on a mechanical ventilator, it's really hard to do a forced vital capacity on a spirometer. So sure, fair. Still, they excluded, yours makes no difference, 50% of their patients they attempted to enroll. And then I had a little bit of a hard time, I think because of the language barrier. Obviously, these guys don't have English as a first language, however, their English writing skills are probably better than mine, so hats off to them. But what they said is they were measuring this forced vital capacity at time of discharge. And then in reading through the manuscript, I think it was really at the time of the patient leaving the ER, because they said they were discharged from their 8-bed intensive care observational area in their ER, either to a med-surg bed, a regular hospital bed, or an ICU bed. And I think if I remember, 7 of their patients were excluded because they were discharged to home directly from the ER. And to be honest, those are patients that I really would care about. But yeah, so at time of leaving the ER, and they also didn't say how long that was, they were measuring this forced vital capacity. And then going into the future, what they were able to find is that folks who had a much lower forced vital capacity, I think it was half of predicted, ended up disproportionately having these bad outcomes. And you folks have heard this before, but did you notice what their primary outcome was for the study? It's a composite outcome, which I hate. I hate composite outcomes because it really confuses how much you should care about this.
But if you throw a bunch of things together, you'll get to yes.
And there, my friend, you have identified how to become a good researcher. The outcome that they were looking for was a hospital-acquired pneumonia, a transfer to ICU, and the need to put the patient on a ventilator, or death. And so if any of those things happened, then you check the box and say that this decreased forced vital capacity is helpful to forecast what the outcome is going to be and how to allocate resources. But I got to tell you, man, if you end up wrecking your bike and having a blood chest wall injury and you go to a hospital, if you end up having at some point to get transferred to the ICU and then you can go home versus you die, are those the same level of things that we should care about?
No, it doesn't seem like it. It seems like there's a little bit of a gulf in between those two.
Exactly. And I can virtually guarantee you, I'm not trying to make accusations, just based on experience, that their incredibly small sample size of 62 patients probably didn't have enough signal in the noise if they just used an outcome of death to come up with the difference, because you're just not going to have that many deaths in 62 patients. So if you then try and allocate your forced vital capacity group that has normal spirometry versus decreased spirometry, you're just not going to see a meaningful difference in death outcomes there. So they had to just glob on all these other endpoints to their primary outcome, poor form men. And then their secondary outcome, I think, was just overall length of stay in these two groups, those who left the ER with a normal spirometry versus a decreased spirometry. Okay, length of stay, great. So here's kind of the one slide elevator pitch that I'm trying to get better at making. So I would very much appreciate feedback as we try to build these. That's a skill that I'm not good at yet. But the background of this is it was a French prospective observational study at a single level 1 trauma center. The methods used were that forced vital capacity at time of transfer out of the ER. Don't know how long they'd been in there. For all eligible patients with a blunt chest wall injury who didn't meet disqualification. And the results were that those who had a significantly decreased forced vital capacity at time of transfer out of the ER ended up in the long term having a significant difference in their primary outcome. And you can see there I put death. I tried to put some fancy animated question mark or something, but I'm just not that good. Because it wasn't death. The primary outcome was all of these other things, some of which are useful and some of which are not. If you were trying to do a elevator pitch on this paper, what else would you put in there, Dennis?
Yeah, there wasn't a lot of people. Like the methods, straightforward. I think the results, they globbed on a bunch of stuff so that they could get published, which is ultimately the main goal. Yeah, like it's, what would I put? Like a confusing emoji on there, because they're like anybody within these giant ranges, like extended care or extended stays, anything negative that happened to them, they lumped into the this was helpful column.
Which means you get to your point, a statistically significant outcome, which means publication, baby. Yes. Nailed it. And, the unfortunate reality is don't hate the player, hate the game. And for those folks who, as doctors, are in those academic institutions, you shall publish to maintain your tenure and all that sort of garbage. And so it's kind of a bummer. I thought this was interesting. This is table 1. Table 1 is your outcomes. You can see on the right, I pulled out anything that was statistically significant. So p-value 0.05 or less. And at some point, maybe we'll do a discussion on why that p-value is kind of a garbage outcome. And a lot of people in research actually do what's known as p-hacking. And they specifically manipulate, might be a strong word, intentionally adjust their data so they can get a positive p-value so that they can get published.
That's right.
But as you
50% of statistics are made up.
Oh man, well, what was that country song? It's like Statisticians Blues. So good. For those of you who haven't heard it out there, you should definitely YouTube that. So here's table 1, and you can see all the different things they measured on the left. The first column next to that is the overall population. Then you can see which of the variables measured on the far left had a meaningful difference between folks who had a normal forced vital capacity versus a decreased forced vital capacity. And again, none of these were that amazing to me. I mean, the very first one is age. So if you're old, and in this case, it was 71 years old on average, you are going to have a secondary complication. And if you're younger, 57 years old versus 71, you are less likely to have complication. Okay, that makes sense. Yeah, what do you got?
Yeah, I mean it's kind of an obvious one.
Yeah, the other two, the next two were a little interesting. So if it was a motor vehicle accident, you were actually more likely to not have a problem. If that makes sense. Which I guess maybe that's
you
because
get
it's
help
younger
faster.
people. So like, because they're
Maybe
okay, yeah,
it could be younger people.
Sure.
They're driving fast. Those young kids.
Mm-hmm. Yeah.
But I would imagine you might get help faster versus you fall down, unless somebody saw it happen and called help. I would imagine like a car accident is pretty dramatic, so you're going to get help faster, I would imagine.
Yeah. Well, and in France, they actually don't have paramedics. They have EMTs and they have physicians that do the pre-hospital. So I don't know how that affects their care delivery, but I can tell you from Big Sky Country, from my great state of Montana, when we look at our state level data, in the state of Montana, you are, as a trauma patient, more likely to die from a ground level fall, which is old people, than you are to die from a motor vehicle accident. So we have more deaths every year in Montana from a ground level fall than we do from motor vehicle accidents, which is shocking. But probably that is because of the confounder that, again, we're looking at age distribution. Younger people drive too fast and wrap their cars around telephone poles. Older people already have a bunch of pre-existing cardiac and pulmonary dysfunctions, hit the ground, and suffer all of those downstream sequelae of pressure ulcers, sundowning, delirium, all the hospital-associated disease processes that cause them ultimately to have their demise.
Yeah. I mean, how many 70-plus-year-olds do you know doing CrossFit?
I'm not going to call anybody out in particular because I don't want to be rude, but yeah.
Yeah. I mean, just exercise tolerance. And believe me, when I hit 70, I'm going to relax. If you think this is relaxing now, you just wait. But, it's just a kind of another reason, like why you need to stay active across the lifespan is if you get hurt, you need that reserve, that physical reserve, to heal. And if you're not, then you're more likely to have a complication.
Yeah, 100%. And then, so just for the other interesting variables here, we can see, I did find it helpful that if you have a hemothorax, you are much more likely to have secondary complications. And then I was disappointed for prognostic scores. You can probably see it there. They listed 3 different prognostication scores for trying to identify patients who are going to have worse outcomes. And only 2 of the 3 scores were actually statistically significant. So this ISS, well, we know the ISS well, not super
Injury
helpful,
severity
which
score?
is, yeah. I wonder if that was, oh, I should have done more research into it. I bet that is the overall ISS, which could be any body system, versus like the modified looking at the chest specifically. I bet that one will be sensitive, but yeah, disappointing. So here's my analysis. I think the pros of this is, you just need your spirometer. You don't need an X-ray. Based on how they perform this study, it was able to forecast who is more likely to have a secondary or a bad outcome. And therefore, if you can forecast who's going to have a bad outcome, you can identify who to allocate resources to. And in our PFC environment, perhaps that means trying to spin up a partisan evac system to do a rat line somewhere. We're obviously not going to go into TTPs here, but that's a really big ask. You have the possibility of having an impact on the operational environment if you evac somebody unnecessarily. And because you're using the spirometer, that's objective and repeatable and comes up with a discrete number. In my mind, I think the cons are that it's not randomized. It was prospective, so my bad. But it's not randomized. It's small sample size with the large exclusion, as we discussed. And it's a single center that, as we saw from that table 1, really looked at an older patient population than I think you and I probably care about in the deployed environment. What else did you notice about this?
I mean, I know I notice those things, but almost all my thoughts have almost next to nothing to do with this paper, other than these were related. So I didn't really like how they set it up. I do like that it's, as far as gear wise, it's something that's ubiquitous in hospital systems. Okay, it's just utilizing a resource. I think it could be refined to something more to what we want, but it's something that's essentially everywhere. Doesn't require a bunch of stuff, and you can do this over and over and over again. I guess what my thoughts is I agree this is probably something that we could, if somebody were so inclined in the operational side of research, to look at, in that, one, it's already something that we should be doing in nursing care, period. It's on our checklist. It's on even the PCC guidelines as well. So it shows like, hey, this can actually help. Just exercising those lungs. If you let their tidal volumes go, their force vital capacity, if you let that diminish, things get worse. So fight against it. And then what kind of led me to from my original question was, if we measured this, if we monitored this throughout their course, could I use this as some kind of triage decision, not necessarily just disposition, which I think it could, but potentially procedures going forward. I don't know, did that make any sense?
Yeah, 100%. And I love that you picked this article because, well, it's not perfect. What it really forces us to start doing is critically thinking about our patient care delivery and the secondary impacts and downstream consequences of that, as opposed to the last 20 years of GWAT, when it was fire and forget TC3 care under fire and then expect a brownout with Allocation showing up. And this is a very different thought process, and I really love that. Speaking of TC3, I loved at SOMA that when Monty gave an update to the JTS COTC, Committee on Tactical Combat Casualty Care, he ended up sharing what the COTC is using as level of evidence. And so, of course, as always, I took a terrible quality picture of his PowerPoint presentation. I might reach out and ask for a higher quality copy. But you can see here in terms of level A, B, or C. Let's see. I think this is a CLD limited data because it's a non-randomized observational study with limitations of execution. So, I mean, from an academic perspective, if we were to grade this, it is in the research quality category that is one up from the absolute bottom of expert opinion. But more importantly, from a PFC grading approach, where would you put this in terms of the PFC grading scale?
So I put that kind of in the middle. I liked essentially what I gathered, because even at the end, I was like, well, I like the thought they executed it poorly, and essentially just everything about it sounded to me like they were setting up their next research funding and saying, hey, this is worth kind of looking into, which I agreed with that. That's about the most positive thing that came out of it for me, I guess, is that, like, yes, there is something there, but obviously way more needs to be researched on it. But it definitely got me thinking of, is this something that I should maybe I should start monitoring and seeing if it does anything, if I can see if it correlates to anything, especially if you can get a small monitor that can tell you that information.
Yeah, I agree.
Yes, I got Alex to agree with me.
I have learned over the years to just go along with smarter people than myself, as opposed to just looking like an idiot. I think there are many great Mark Twain quotes, as well as Yogi Berra. And I believe it was Mark Twain who said, it's better to keep your mouth shut and let people think you're an idiot than to open your mouth and confirm their suspicions. And that is definitely something I've been trying to do better about.
The people that know me outside of this podcast, no, I don't talk very much for that particular reason.
For sure. And well, I think this is an interesting one to dissect, both in terms of its application to the operational environment, as well as just kind of getting a little bit better understanding about how to dissect papers. Anything else you got on this one?
Yeah, no, I definitely enjoyed going through this with you. Like I said, I think it's, even though it's a nothing paper, picking apart why is it a nothing paper, even though I liked what the idea was, it didn't move the needle really in one direction or the other.
Yeah, fair. Cool. Well, we're always open to submissions and ideas for different papers. If anybody wants to chat about it, always love to hear from folks out there.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.